This baby, this baby has a maternal thyroid disease. What would be your option? Somebody is giving an option of B, repeated term. Very good. Any other option? Very good. I think all of us are quite well, neonatologists are quite well. Right. We will come to the answer for this question. This is the term, preterm baby, 32-weeker, maternal thyroid disease, RDS. Somebody goes in for a venous TSH. Venous TSH is done on day 10. The venous TSH is 10.3. Venous VT4 is 1.1. Remember, the ISPAID cutoffs are for both term babies and preterm babies. Babies with mothers having hypothyroidism, without mothers having hypothyroidism. Sick babies, well babies. Everybody, the cutoff remains the same. I reiterate the cutoff: screening TSH of 20, venous TSH of 20 and 10 is in the first 2 weeks and beyond 2 weeks. Total T4 below 8 micrograms per DL, free T4 below 1.1 micrograms per DL. So this baby TSH is 10.3, but this is just day 10, first 2 weeks of life. The free T4 is 1.1. So what would you do? The last case in the newborn section. This is a preterm baby. Screening TSH is not done. A venous TSH is done directly. The TSH is 2.3, but the total T4 is 4 micrograms per DL, below 8 micrograms per DL. You're looking at a baby with a low T4. TSH is normal. Reassured? Would you start thyroxine? Would you repeat the TSH along with the free T4 at term? What would you do? Very good. I'm glad everybody is awake and alert. Right. So, how would we tackle? See, remember, these are high-risk cases. Maternal thyroid disease, preterm babies, and maternal Graves' disease. In maternal thyroid disease, the antibody can cross the placenta and will not allow the TSH to act. It will not allow the thyroid to develop properly. They develop transient hypothyroidism. Be careful. This is our own study where we found out that the risk of hypothyroidism is extremely high in babies born to mothers with thyroid disease. This is a preterm baby who has hypothyroidism, but the test fools us. Why? Because the axis is immature. The TSH is suppressed because of the abnormality of the HPT axis. So what is it that is happening? The screening is negative, but the baby has congenital hypothyroidism. So all preterm babies must be screened, re-screened at term. Retesting is mandatory in preterm babies at term. The second problem in preterm babies is they have a false low T4 because of the sickness, because of the medications, because of the immaturity, because of the poor maternal contribution. They have no hypothyroidism, but they have a low T4. They need not be treated, rather they should be monitored and followed up. They should not be treated, but they should be monitored and followed up. Lastly, babies have a mild elevation of TSH, but they don't have hypothyroidism. They have a very mild elevation of TSH, but they don't have hypothyroidism. So preterm babies, you can have false positive, false negatives. Maternal hypothyroidism, you can have false positives, false negative. So this is again our own data in preterm babies with congenital hypothyroidism. So how should you approach? Screen all babies, irrespective of the risk factors, by 48 to 72 hours. If the screening is more than 20, please follow the ISPAID guidelines. Do a venous test and interpret accordingly. If the screening test is below 20, that is, it's a screen negative baby, retest by term or at discharge. Retest at term or at discharge. Again, the same cutoff. If the TSH is more than 20 in the first 2 weeks of life, more than 10 beyond 2 weeks of life, total T4 below 8 micrograms per dl, free T4 below 1.1 nanograms per dl, consider treatment. So coming back, what would you do for this baby? Even though this baby has a normal TSH, this baby can have a delayed surge in the TSH. You should repeat the test at term, and you should not miss a hypothyroidism with so many risk factors. What would you do in this child? Yes, this child has a mild elevation of TSH, but this may come down. So this may be transient hyperthyroidopenia. Repeat the test at term. This test has a low T4, but remember there is an illness. The child is very sick, child has a respiratory distress syndrome and is on the ventilator and receiving surfactant therapy. The illness may be responsible for the suppression of T4. Repeat the test at term. If the ISPE guidelines are satisfied, you may have to start this baby on thyroxine replacement. Right? So, have we understood congenital hypothyroidism? Have you understood congenital hypothyroidism, the neonatal thyroid screening, the approach to investigations, the approach to management? I'll see if I have missed any questions so that you. So sick babies with risk factors should be screened like all babies. Screen at 48 to 72 hours. But repeat the test irrespective of the initial screen when they reach term or prior to discharge. When they reach term or prior to discharge. Is it clear? Right. Again, 10 to 15 microgram per kg. Yes. 10 microgram per kg if the T4 is normal. 15 microgram per kg if the T4 is low. Right. So I'm very happy that everybody is actively discussing, actively answering the question. So don't worry, I will share this PowerPoint to the organizers once I remove some pictures so that you can have it as a useful reference. I have done none of this is my own thing. I've just copy pasted it from the guideline. You can have it if you want it. Can we go to the next case? Right. This is a 7-year-old child with obesity, poor height gain, constipation, and bradycardia. Obesity, poor height gain, constipation, bradycardia. You have a strong suspicion of a symptomatic hypothyroidism. You do a test. The TSH is found to be 45. All of us know it is elevated. Free T4 you see is low, it is 0.6 below the lab recommended cutoff, but the free T3 is normal. Free T3 is 2.1 picograms per ml. So how would you do proceed? Is it A? Because the free T3 is normal, we can observe the child. Or you would start thyroxine replacement. Or you want to know the cause of hypothyroidism, you would do an FNAC. You would refer this child for a FNAC. Let us see. Excellent. I think everybody is well charged. So most of them want to start thyroxine replacement. So what do the guidelines tell us? Remember, the TSH is very, very, very sensitive to minor fluctuations in the thyroid hormone levels. Abnormal TSH is the first sign of a thyroid disorder. So there is a log linear relationship. When the TSH goes up, the T4 comes down. When the T4 goes up, TSH comes down. When the T4 goes low, TSH goes up. So it's an inverse log relationship. Low T4, high TSH. High T4, low TSH. Here you're looking at a baby who has a low T4 and a high TSH. You're looking at a child with primary hypothyroidism. So the higher the TSH, lower would be the T4, but free T3 is maintained normal till the end. The body tries to protect itself from symptoms. So free T3 is a poor indicator of treatment or symptoms in primary hypothyroidism. PT3 is a poor indicator of thyroid function in primary hypothyroidism. So TSH is the most sensitive tool. So in this case, you remember the baby had a high TSH, a low T4. So you established the diagnosis of primary hypothyroidism. So what would you do? Many of you did not want to do an FNAC. So what would you do? You have to measure antithyroid antibodies, antithyroid peroxidase, antithyroglobulin. I repeat, antithyroid peroxidase, antithyroglobulin. If the antibodies are negative, you consider other tests like an ultrasound or a technetium or an FNAC to look for alternative causes. The most common cause of primary hypothyroidism in a 7-year-old child is autoimmune thyroid disease or Hashimoto's thyroid disease. So an antibody would be sufficient. And this is a very interesting slide which tells you the prevalence of antibodies in different settings like hypothyroidism, Graves' disease, and normal children. And look at the table very carefully. Majority of the children with Hashimoto's thyroiditis has TPO, positive thyroid peroxidase. So thyroid peroxidase antibody is the most useful test to identify autoimmunity in hypothyroidism. But remember, there is a caveat. Even normal population or early thyroid disease children can have a positive TPO. So your therapy is determined by the thyroid function test. The etiology of the hypothyroidism is determined by thyroid peroxidase antibody. So one single test, you're looking at a child who is not affordable, you want to cut down the cost, one single test to tell them the cause for the primary hypothyroidism would be a thyroid peroxidase antibody. And remember, be very, very careful about writing the test. There is something called as thyroglobulin. There is something called as thyroid binding globulin. And there is something called as antithyroglobulin antibody. Thyroglobulin is done in thyroid cancer patients to see for residual thyroid tissue. Thyroid binding globulin is a test that is done to identify a genetic disorder, TBG deficiency. In autoimmune thyroid disease, you measure antithyroglobulin antibodies. So whenever you're giving a prescription for investigations, be very clear in writing the investigation. Antithyroid peroxidase antibody, antithyroglobulin antibody. And pick up children with Hashimoto's or autoimmune thyroid disease. So most of you get the right answer. Overt primary hypothyroidism, start thyroxine, check for antibodies. Now what would be the dose of starting? This is a 50 kg baby, poor height gain, 7-year-old. Let us see what is the choice. 50 kg. T4 is low, TSH is high. So what would be the starting dose? Would you choose A25, B50, B75, D100, E150? I'm very keen to see what is the choice. Somebody has chosen an answer B. Let us see what are the other choices that people are choosing. Somebody has chosen 25 for a 50 kg child. I repeat, the child is 50 kg, child is symptomatic, child has biochemical overt hypothyroidism. So what would be the choice? Everybody has given answers. Let us see what is the choice. Right, very good. I'm glad everybody has given the answers. Let us see. Remember, treatment of juvenile hypothyroidism is an art. It is an art in itself. So how would you treat this baby? A symptomatic child 50 kgs with a biochemical hypothyroidism. The dose would be 100 microgram per meter square or 3 to 5 microgram per kg in a young child and 2 to 3 microgram per kg in an older child. So 3 to 5 in a young child, 2 to 3 in an older child. So what would be the starting dose if as per this 3 microgram per kg because child is 7 years old and the child is 50 kg. So 150 would be the dose that this guideline tells you. But remember, start with about 25 to 40% and step up slowly. Why? Because they don't tolerate such high doses. Start on a low dose. What would be 25% of 3 microgram per kg? That could be somewhere around 40 to 50 microgram per kg. You slowly increase the dose and start on a low dose. So in congenital hypothyroidism, you have to be aggressive, be rapid like the rabbit. In juvenile hypothyroidism, be gentle, be slow, but be steady like the tortoise. So what would be the starting? This is our own paper where we showed that more delayed the mornings, more symptomatic the child, more slow should you be in starting thyroxine. So what would be, as many of you gave the right answer, you start off maybe on 1 microgram per kg. See how the child tolerates. See the trend of the thyroid function test every 4 to 6 weeks and slowly escalate the dose to attain a euthyroid state over a period of time. See, in congenital hypothyroidism, you are interested in preventing mental retardation. You are interested in preventing a long-term neurodevelopmental sequelae. You are interested in attaining a euthyroid state early. But in juvenile, you want to be gentle. You don't want to overtreat. You don't want to push the child into trouble. You start off with a small dose and slowly escalate the dose. Right. So this would be the approach to juvenile hypothyroidism. Right. I think I have a small thing for the organizers. I have 5 more case scenarios. I think that it will be difficult. Everybody is participating with so much of enthusiasm. Can we have a second part of the session next week?
You want to continue now or you want to do in a session, sir?
I think it will be very tedious for everybody. More than an hour thyroid. It's almost, I didn't realize we have almost 50 minutes.
Yeah, fine, sir. Then we'll do it in the section again.
Yeah, it's up to them. I'll send this PowerPoint if you want. If you want to have another session also, I'm okay.
Yeah, we'll do this session next week. If you are
I'll go to the take-home messages because it will be kind of a revision of what we discussed today. Thyroid is very interesting. The more you read it, the more you practice it, better it will be. So as far as congenital hypothyroidism is concerned, look at the test, don't look at the baby. This may look very crude, but congenital hypothyroidism is one condition where the clinical symptoms are very minimal. It is more of a lab abnormality. Screening TSH below 20 is screen negative, provided there are no risk factors. Screening TSH more than 80, aggressively take a venous test and treat without waiting for the reports. Between 40 to 80, do an immediate venous test. See the reports and initiate treatment. Between 20 to 40, you would do a venous test in 7 to 10 days. If the TSH is more than 20, 10, 8, and 1.1, these are the 4 golden numbers. Screening TSH more than 20, venous TSH more than 20 in the first 2 weeks of life, venous TSH more than 10 beyond 2 weeks of life, total T4 less than 8 micrograms per dl, free T4 less than 1.1 nanograms per dl would warrant treatment. In congenital hypothyroidism, start on a full dose, 10 to 15 microgram per kg, aggressive follow-up, and quickly attain a euthyroid state. In juvenile hypothyroidism, calculate the dose, start on a low dose, slowly escalate with monitoring, and try to attain a euthyroid state. Aggressive treatment of congenital hypothyroidism, gentle treatment of juvenile hypothyroidism. So I think this is the main thing that I would like to enforce. The next set of cases are thick euthyroid, subclinical, central, lab errors. the precautions to be taken, they are all a little, what do you say, off the track. So I leave it to you. I am okay with anything.
Fine,
Any
so we'll do next Thursday, we'll do the second session.
we will discuss whenever it is convenient. We will do it.
Thank you, sir. Any questions from the audience?
I think everybody has been discussing in the chat, and I'm going on answering whenever they are asking. I think we'll wind up.
Yes.
Thank you. I think very interactive. I'm really surprised that everybody is participating so much. It is it's very gratifying. Yes, somebody has asked me what is the maximum dose to start for children. See, I would say as far as congenital hypothyroidism and juvenile hypothyroidism, two different ball games. In congenital, it is 15 microgram per kg. Don't worry about the upper limit because you're going to be monitoring the babies, and it's going to be started intrauterine. So 15 microgram per kg full dose would be the starting maximum dose that you can do. As far as juvenile hypothyroidism is concerned, the upper limit, it depends on the body weight and body surface area. Literature says up to 250 micrograms people have done. So the starting dose would be very slow and slowly escalate. The maximum dose to start, there is no maximum dose to start. You calculate the whole dose and start off with around 25% and slowly advance the dose. Child with congenital hypothyroidism comes with follow-up. Child taken the tablet morning and then done TSH. TSH dropped from 100 to 5.5 in a span of 3 months. Should we decide? See, it's a very important question, which I'm glad you have brought it up. The time period between the test and the tablet, what should it be? I think there is a European guidelines. I'm happy to share if you want. In an ideal world, the test should be done before the tablet, or for logistic reasons, you have taken the tablet and then doing the test, it should be a gap of 4 hours. Morning 8 o'clock, the tablet has been taken. After 12 o'clock, you can do a test. That's the European guideline. So the impact of the tablet on the test is going to be hardly anything. And the drop of TSH from 100 to 5.5 is gratifying because you're dealing with a child with congenital hypothyroidism. As far as the free T4 is normal, it would be quite reassuring. Monitoring the dosage and also hyperthyroidism. See, in juvenile hypothyroidism, you would have to monitor the TSH and free T4 and clinical symptoms and tolerability. So you would have to ensure that the T4 and the TSH are in a normal range, and TSH can be permitted up to a mild value of around 10. And you should avoid hyperthyroidism, elevated free T3 and free T4 in juvenile hypothyroidism. Any other question? Very good question. Complaints of drug based on companies. See, I think regarding the potency of which company is good, which company is bad, really that cannot be answered because there are no head-on studies comparing Abbott's or comparing GSK's or comparing Merck's thyroid brand with, that sort of a head-on comparison has not been performed, and it is not required also. All the drugs pass through the DGCA approved stringent regulations, safety studies, efficacy studies, and then only they are released into the market. So I think we'll have to presume that all of the thyroid medications are deliver the same amount of thyroxine that is depicted in the label. And of course, the biochemical test is one piece of the jigsaw puzzle. The adjustment is done based on See, I'm very glad you have raised this question. I faced an issue with one company and changed to another. See, I wouldn't say it would be wiser to blame the company. Maybe that particular batch was ineffective or something like that. And I would like to also draw your attention to a pinch of salt that at the same time, suppose today I draw my blood and do my TSH in four different reputed labs. All the four would give four different results. One would give a TSH of 8, one would give a TSH of 12, one would give a TSH of 3, one would give a TSH of 5. So it's not that one lab is better than the other or that lab is inferior. There are so many factors in these immunoassays that are going competitive immunoassays that that are going to influence the TSH level, the carryover effect, the washing effect, etc., etc., etc. So I think one has to remember that the symptoms, the growth, the development, the biochemical parameters, etc., everything has an equal contribution that we have to keep in mind about the um, adjustment of doses. Somebody has asked that batch was. There is a recent thing that an erroneous batch packing has been done, and that has resulted. See, most of the times, what happens is you have to remember that whenever you put a child on thyroxine, you are definitely going to explain to the parents that what are the signs of overtreatment, tremor, weight loss, irritability, unexplained diarrhea, etc. You're going to put a word to them that this is going to be the side effect of the medication. So when parents are alerted and they come across such symptomatology, they're going to immediately revert back to you. And many a times, what happens is, even for example, let me put it this way: we have children with many transient congenital hypothyroidism who do not require 15 microgram per kilogram of thyroxine. They may require just 1 or 2 microgram per kg on a temporary basis. But if you put them on 15 microgram per kg, they don't come back with hyperthyroidism or a thyrotoxic crisis. Body has its own way of juggling around things. When it finds that the thyroxine levels are going up, it kind of shuts down the conversion of free T4 to free T3 and shuts up the conversion of T4 to RT3. So a relatively inactive form of T3, which kind of keeps the child going without symptoms of hyperthyroidism. So you have biochemical hyperthyroidism in a clinically well child when the doses are relatively high. So body is something which really is a fighter, especially in a young kid. So I think we have to remember that. But of course, keep it in mind, regular follow-up, periodic education is a way to keep this under check. On what about dosage would you advise monitoring for BP, ECG? See, the dosage routinely, there is no need to monitor the ECG, etc., in congenital hypothyroidism, because unless you find signs of hyperthyroidism, very disproportionate tachycardia, you're suspecting an arrhythmia, it makes sense for you to do an ECG. Otherwise, routine ECG is not mandatory as far as childhood thyroid disorders are concerned. Regarding blood pressure, yes, children who have features of hyperthyroidism, definitely you would have to see children who are exposed to thyroxine poisoning, who are exposed to Graves' disease, whether you want to take a therapeutic decision about starting them on beta blockers or not. I think that is where a blood pressure comes into picture. A point or a red flag where child to be referred from pediatrician to endocrinologist. See, I think that is something that you will have to individualize the treatment plan. Attainment of a euthyroid state with close interaction between the pediatrician and the pediatric endocrinologist is what would be the right way forward. To give a euthyroid state, normal growth, normal development, and to mimic physiology. Probably expert help could be taken when you're looking at a child with a hypothyroidism and a comorbidity. A very late presentation of hypothyroidism with a severely compromised height. Hypothyroidism with a pubertal abnormality. You have a hypothyroidism with, say, precocious puberty, hypothyroidism with delayed puberty, hypothyroidism with a fracture, hypothyroidism which is not showing features of catch-up. Thus, these are children who would require more inputs in terms of association, whether you need to put them on all other forms of treatment. I am so glad everybody participated and we have finished on time. The remaining cases are just, lab parameters and, those kind of things. I think you would be the best. You would be able to take it forward from there. Thank you so much. I think can we wind it up, organizers?
Yes, sir. Thank you very much, sir. Very informative and interactive session. I hope everyone got the points what they wanted from the class, and I hope we'll take the next session and finish our requirement.
Thank you. Thank you very much.
Thank you.